Welcome to Doc Talk Live. Good afternoon or evening. It's a beautiful day outside. I'm Dr. Goodman. This is Doc Talk Live, and I'm with Dr. Nathan Redmond.
How are you all?
Nathan, I'll give you the new high five. Dr. Redmond, I appreciate you doing this this evening. Nathan is a dentist.
I am.
And we've had a request from one of our viewers to cover Bruxism and TMJ, and so we scheduled this weeks ago before COVID happened, but fortunately you're my next door neighbor, so he just walked outside and here we are. So that was pretty simple, and so before we get to TMJ and Bruxism, I'm kind of curious how COVID affects dentistry, because when I need to see a dentist, it's generally pretty urgent. I'm not very good at going when it's not urgent, when I don't have something wrong with my mouth. So what's going on in your world?
Well, Brad, we have received directive from a lot of our governing bodies. Clearly, our dental board protects the citizens here locally. Every state has a dental board, and so they're the ones who provide the rules and regulations for how we practice. And in conjunction with working with the local public health department, state public health department, they've limited our scope of practice to emergencies and urgent needs. And so, based on the practice that the great thing about dentistry is that we can choose how we practice. There's practices that do a lot of cosmetics, practices that do, we have specialists that just do root canals or braces. And my practice is kind of unique because I have 3 practices, and one of my practices, we don't even do hygiene. So we only see urgent needs. And so we kind of fell directly into this, and we're doing our best to remain open so that way we can meet patients' needs in our community.
But you're getting right in there into the oral mucosa, where people sneeze and where a lot of these, if the pathogen was there, I mean, that's a great place to find it. So how do you protect yourself, and how do you protect yourself from other patients?
Well, that's a great point, because it's evolving. Today,
that is an interesting word, evolving,
yes,
because
yes.
We did a Doc Talk Live yesterday, and one of the great stressors for me in doing this was it seems like things are changing minute to minute. I mean, minute to minute, not month to month or week to week or day to day. I mean, minute to minute. It's crazy.
It is. We're receiving daily or even twice a day directives on how to change our pattern of practice. Now, I can tell you in dentistry, I feel like that as clinicians, we may receive probably the most hours of training in this area, because we are working over a highly effective area. I would dare say, the most one of the most dangerous things you can run into is another human body, when you're coming into contact.
Sure, and especially like a mouth bite could be very dangerous to somebody.
Exactly. So what, starting, our first year out of 4 years of dental school, every year we receive intensive training on infection control. And after we graduate, we're required 4 hours of training every 2 years on infection control. And that's just to maintain the safety of ourselves, our patients, and our staff.
So I imagine you always wear a mask anyway.
Always.
Do you have, the masks are in short supply, so how has that affected your practice?
I had some foresight, and I ordered a reasonable supply of masks, not a horde of masks, but enough to supply my clinics with a supply. However, just today, the regulations change on mask usage, that the simple square mask that you see most dentists wear in their offices will not protect from the inhalation of the virus. And so the concern is, so the concern is that if we have a procedure where we have to actually use a drill on someone, and it creates aerosols, that we run a risk of vaporizing causing inhalation risk for ourselves.
Do you have the special masks?
We don't. They're still not available, and so we're going to have to limit those procedures. Even this morning, I had to do a surgical removal of a tooth where I had to remove bone around a tooth with a handpiece, causing aerosols, and get the tooth out. So I'm going to have to be very selective about which patients I can treat.
Do you have to use a screening? Do you use a screening process?
We will. We're going to have to, and sometimes you don't even know if you're going to get in that situation. It seemed like it was going to be a simple routine extraction, but the bone was very dense, and so the tooth didn't come out through just standard extraction techniques with extraction instruments. So it had to be surgically removed, and so sometimes our back may be against the wall, and I may have to excuse my staff and just choose to put myself in that position, without my staff being at risk.
All right, well, are there any questions so far, or are we good?
No.
Can't tell, good. All right, so let's talk about TMJ and Bruxism. So let's start with TMJ. If I eat a bagel, you can hear my jaw popping from your place next door.
I believe I did hear that for work.
That's true.
But I have no pain. I'm totally asymptomatic.
And that's the typical. That's what most people typically experience. 90% of people will have asymptomatic jaw popping at some point in their life. 90% of it will resolve and return at some point, typically. So most people with jaw popping, it's not a cause to be concerned. It's just part of having a jaw, and it's unless it becomes something that interferes with function, with life, with rest, with talking, with eating, then there's no reason to address it.
So how do people get TMJ?
Well, this is a knotted ball of yarn that is very complex, and without spending 5 or 6 hours in this discussion, I'll start it off with this because it's one of the most complex issues in dentistry, actually. I used to be on the National Board for Continuing Education for the Academy of General Dentistry, and several stakeholders in this field came and they went to have a consensus conference to try to figure out how do we treat this, and this was about 2003. And this group that I was on that governed the education of general dentists, they were apprehensive to do this because the last time they had a conference like this about 15 years ago, it actually wrapped up in fistfights between this stakeholder and that stakeholder. So move forward almost 20 years now. A lot of people have been hard at work at this on the academic level, clinical level, and we've actually established our newest dental specialty, the oral facial pain specialty. And this is a new specialty to address all these problems. Bruxism, temporomandibular joint disorder, what most people call TMJ, we call TMD. And so we have now developed treatment protocols. We've developed.
Are you sure you're not a lawyer? Because you said a lot and you haven't said anything.
Well, that's the problem. and I start with my patients with this because and we have a patient that comes in with a problem, and the problem usually starts. Dr. Redmond, I've been hurting this way. And so there are two questions that I ask first. How long has this been going on? Well, the first question is, how long has this been going on? So you're going to get two answers. Well, it just started last week, or last night I got this bad pain, or it's been driving me nuts for 3 months, 3 years. And so we have chronic, we have acute pain.
Okay.
And so these chronic and acute pains, you've got to start unwinding this because it can come from about 6 different causes.
Okay, so and it sounds like people have various stakes in this in terms of what they believe.
Absolutely.
So tell me your dogma, if you don't mind.
The place you start is do as little as possible first to see if you can find relief. This is like going swimming and you've never seen a swimming pool. You've never been near water. Let's say you've lived in a desert your whole life. So you want to start like a zero entry pool where it just slopes into the water. You literally want to take baby steps into the water because you don't know how to swim and you don't want somebody throwing you in the deep end because the choice as a patient, you're going to make you don't have to make choices, and some of those choices can't be undone.
So go through the basic stuff quickly, because I'm sure people with TMJ
Absolutely.
have been through all the basic
Absolutely.
stuff, and people without TMJ, they probably aren't interested anyway. So
Absolutely.
go through the basic stuff quickly.
So the biggest thing, it's for acute cases, the people that come in, and it's the first time that they felt anything like this, and they're hurting.
Okay.
Okay. Usually that is a muscular issue. So they're having a spasm in one of the muscles that open and closes the jaw, allows us to chew, to talk, and so when that occurs, we tend to offer anti-inflammatories, maybe some type of muscle relaxing medication, and recommend cold compresses and just a simple soft diet, just to relax those muscles, to get things to calm down, to where the inflammation can work its way out. Sometimes it can take a couple of weeks, but just simply to just get things to calm down and make sure that it's not a structural problem or a chronic problem or neurological problem that's forming.
Just basic stuff, basic first aid stuff.
Right.
Okay.
The next level above that is something that is becoming kind of subconsciously habitual, which brings us to like Bruxism. Okay, where we use our mouth for two different things. We use it to satisfy ourselves and to actually show aggression. Clench. To get the
I have bruxism as well, by the way. So
Right.
my jaw pops and I grind my teeth. Okay.
Absolutely, and actually, it's about 40 to 60% of us do that. And we have night bruxism and day bruxism, and some people have both. Some people have one or the other.
I'm just at night.
Yeah, and so most people at night will wake up and their jaws will be tense when they wake up, maybe have some soreness in their teeth, but during the day it tends to abate and the level of discomfort comes down. Day bruxism is the opposite. You wake up, you're fine, and the tensions of the day occur. You clench, you're at work, you're frustrated, you're biting your tongue, clench your teeth, and your discomfort goes up, and then it comes down at night. And so for those people, we tend to recommend oral appliances, splints, and things like that.
This is the day people?
Both, because
Okay.
there are different types of appliances we can offer, and obviously during the day they can be a little bit more interrupting. But if you have a job where you're not having to communicate, you're just at a desk, you can wear your appliance, or if you're working on a line at Honda, for say, you can wear an appliance because you may have a welding mask on or something, and then so a lot of people do wear these at work. I mean, my wife actually had a dislocated temporomandibular joint disc once, and she wore an appliance at work, and she's a busy attorney, and so she had orthoscopic surgery from her one of her joints, and so. And
I will tell you, appliances have been recommended to me, but I won't wear them.
And that's the thing. All of this, unfortunately, comes down to patient compliance. And I guess it's a good time to mention this because we're early in the discussion.
Well, I feel like I'm asymptomatic. So, I mean, I'm grinding my teeth, but, I mean, it's not really causing symptoms.
Well, in your situation where you have asymptomatic bruxism, where you're just wearing teeth, maybe have some clicking in the jaw, if it's severe, where you're having severe wear of the teeth, sometimes we see patients that are heading to where they're going to need tens of thousands worth of dental work to repair those teeth. And so I just tell them it's a penny saved, a penny earned, where you.
But I've heard it for 25 years or more. So you'd think it would have happened already.
Well, you'd be surprised. Some people it's a very slow thing where it's a very minor amount of wear over years. And I have some patients that have worn their teeth almost to the gum line. I mean, it is remarkable how much that some people can wear their teeth down. But as far as going back to the splints and appliances. The whole trick with a splinter appliance is like this. You don't walk around with your hand like this. You don't walk around with your hand clenched like this. And when you splint somebody's arm, in your business, you put like a ace bandage roll or something in there for them to be kind of in a neutral, relaxed position.
Okay.
And so what you're doing is you're parking the jaws in a neutral position to where you're not able to put as much force on the joint and generate as much force in the muscles. And so not only does it protect the teeth from wearing, it also relaxes the whole apparatus. And if you think about a pair of garden shears when you're cutting like a stick, you get the most power here. So we load the splints in the very front and the tip. You're not actually able to generate as much force here.
So who puts these splints on? Is it the dentist or is it like an orthotist?
Well, it's a dentist, and we're trained to do that, and our dental laboratories know how to fabricate these splints. There's a number of different types that we use based on the diagnosis and your symptoms. And so we take simple dental impressions and a couple other measurements of your mouth and your jaw positions. And we're able to send those with a prescription to a dental laboratory, and the dental technician, laboratory technician, fabricates that based on the prescription we write for your situation. You come in. Now the big important thing about any oral appliance that you have made is follow up, and you know because dentist. A lot of times the dentist needs feedback on how well this thing's working.
Sure.
And so it's important to make return visits. You're not going to fit it with a pair of shoes. You know, this is something that needs to be adjusted based on your experience after you go home and wear it.
Are there any questions out there? Are
No.
we good?
You're good.
We're good. Okay. So we've talked about the splints. What's the next on this ladder of?
Okay. The next on this ladder is where you kind of get, because we're kind of in the weeds at this point. There's other things that can cause this pain, and so the good thing about the first things we talked about, medication for a couple weeks, calm things down. The splint, completely reversible. We're not changing your body.
Sure.
You know, we haven't done anything. So the next thing we need to look at: do you have some type of underlying condition that might be causing these problems? Do you have some neuralgia, like trigeminal neuralgia? Do you have arthritis in your joints? So we start really investigating what's going on. You know, the same thing is, it gets down to a lot of what you do when you're starting to
absolutely.
Look at this. And so a lot of times with this level, we rely on our dental specialties. We have advanced imaging systems in dentistry now. We take 3D images of joints and jaws, and so we can really get down. We can really do some really detailed examinations, and that's really key to the next step, to figure out what direction do we need to go, because from the first 2 points it really goes like this. You know, there's a lot of places.
So I can imagine that you get an imaging study. Is there a question there?
Yeah, this is a question. Thoughts on dry needling to help relieve bruxism?
I'll get to that, yes. And I'm a firm believer that some of our allied medicine and even non-traditional medicine can be helpful.
But bruxism or TMJ? I would think TMJ.
Well, TMJ, bruxism, that's more of a functional kind of habitual thing. My thing is like, if you find that it relaxes you, because we think it is related to stress and muscles being in stress, it's a reversible, procedure that has no consequence except maybe a therapeutic, goal gain.
So thumbs up on dry needling.
Okay. Even here in Alabama, Blue Cross Blue Shield is, I think, providing for dry needling now, aren't they?
I don't know, but getting back to the imaging. Okay, so if you get an imaging study,
right,
I would imagine it's either going to be normal or you're going to see some anatomic abnormalities.
Absolutely.
And the TMJ, as I recall, this joint is a meniscoid joint.
It is.
Like your knee.
It is.
It has
Absolutely.
like a cushion in there.
Right.
So do you see torn meniscuses in that joint? Can you pick that up on?
Absolutely. You see, but in the complexity of the joint, so you think about your knee joint.
Right.
The amazing thing about the okay, so here's the joint, and here's the I wish I had something to hold up here. Let's do this. So sorry, this is low tech demonstration here.
That's all right.
But if you have the joint of the jaw that sits in a cup like this and rotates, but it doesn't just rotate. It also translates forward like this. So as you move forward, and rotate, and so it's a unique joint in our body that it slides as well as rotates.
Interesting.
And so, but to allow it to do that, it sits on a disc like this, and so it rotates. And as you move forward, the disc moves forward. And it's connected to the back of the meniscus with the ligament that helps it pop back as you move your joint back.
Okay.
Now, my wife's case, hers dislocated completely, the disc located completely forward, and so she had to have an orthoscopic surgery where they filled with saline and allowed the disc to pop back into place. And so you can have a number of things. You can have arthritis, you can have a dislocated disc, you can have a torn meniscus, you can have anything that goes on with these meniscus related joints like you deal with.
So it seems like if you've got a chronic problem with your TMJ, and you really do need to discover what's going on anatomically at the joint level. Is there arthritis?
Absolutely.
Is there a meniscal tear? Is there some ligamentous laxity?
Right.
And I guess this is where the art comes in terms of really sort of fixing these or knowing how to fix these.
Absolutely, and we're learning that that's a structural issue, and so then the surgeons get involved and they look at doing all the way to joint replacement, and so we can put an artificial joint in artificial condyle.
I have another question. What if we have constant cracking and popping in the joint? Is that an issue?
As long as it's not symptomatic, like if it's not hurting, then I know it's a nuisance, and there's really not a lot that can be done for it. You can, a splint may alleviate that, but short of that, if it's, I think
Mine, we started the show with it. Mine pops all the time, and it's disturbing to others, but it doesn't hurt. So
yeah,
I'll leave it at that.
And I wish I could offer more, but like I said, if it's not interrupting your ability to enjoy foods, to speak, and it's just a nuisance, talk to a doctor about a splint, see if that helps. But short of that, there's not a lot that can be.
What about my practice deals with injections,
Mm-hmm.
and so I see a lot of joint problems.
Absolutely.
And the TMJ is actually a fairly easy joint to inject.
Mm-hmm.
And I've put steroids in a few joints, and actually they've done quite well. But taking that to the next level, what about, we do a lot of PRP, like
Mm-hmm.
rich plasma, where we take people's blood,
Absolutely.
we spin it, and I don't have any experience with TMJ and PRP or stem cells or things like that.
And we're starting to employ that as well, and we're using PRP in all areas of dental surgery now. To assist in bone grafts when we're doing dental surgery for implants, but PRP has been used. I know some of my colleagues do use that, some of the surgeons, and steroids, of course, stem cells. I'm sure that there are people out there, doing the same therapies because, it's just yet another joint. If it's a tool in your toolbox, or oral surgeons, they're, for those of you who don't know, an oral surgeon goes to dental school first, then typically goes back to medical school, so they're well versed in the same things Brad's trained in, not the same level because they have to deal with some even more things, but they reach into that toolbox that you have,
Okay.
and they try to stay on top of what's available to help their patients. And again, an injection is not as invasive as a joint replacement, and that's exactly what you do.
Absolutely.
I'm a very conservative dentist. I am. If we can avoid the next step, you are better off.
What about topicals like Voltaren gel
Mm-hmm.
or lidocaine gel or a lidocaine patch or some sort
Right.
of anesthetic that you just sort of you go to sleep at night and you just put it on your skin
Mm-hmm.
and let it seep in. Any experience with
Yeah,
those?
well, clearly those things can help with symptoms. Again, we don't want to use those if there's an active problem, especially a problem that is progressive, that we don't want the disease to get worse. So again, we want to, rely on treating, and diagnosing the problem properly, and getting a good treatment in
And
place.
do people have to wear these splints during the day as well, or do they just wear it at night?
Well, most people wear it at night. That tends to get enough pressure off, the teeth. I do have some patients that wear them at night. Sometimes we make smaller, thinner splints during the day. Much like, millions of people are wearing invisible braces. And some of the simpler splints, some of the basic ones are no different than that. Just very, very thin, clear pieces of plastic. You may not even know the person at work beside you is wearing their invisible braces. And so some of our simplest splints are just simply that. They're not as therapeutic as the more advanced ones, but they can do enough to get you in a position during the day where it doesn't interrupt life as much.
Any more questions out there?
No.
Because I'm plumb out. I mean, have I covered everything, or what have I missed?
I guess the what's beyond this is that one of the most recent findings that we have in this is TMD and oral facial pain's relation to sleep apnea, and that we're finding that interruption of blood flow, the position of the mandible at night, is a big factor in all of this. And so if you go to a dentist and he ends up recommending you to an oral facial pain specialist, a dentist that handles these things, or the dentist there has trained in this area to where he can help provide some remedy for you, he may ask you to do a sleep study.
And what is the link between sleep apnea and TMJ?
When your oxygen levels fall significantly at night when you sleep, the inflammation builds in the muscles that are inflamed and aggravate everything that we're dealing with, and creates more tension in this area that your body's tensing up. And so, because all this problem, it goes from here to about, it's really head to shoulder. And so what we're trying to do is we're trying to take a very, very broad approach, and we found that a lot of this is caused by a lot of times multiple factors. Your diabetes can be a factor in this, by keeping inflammation high. There's a number of medications that can aggravate this, from SSRIs and whatnot. And so getting with somebody who can, a complete medical history and dental history is key to finding solutions in this. And so when you go sit down with somebody who really has solutions for this, they're going to ask you a lot of questions. You may think a lot of them are not relevant, but we found that they truly are. And that, there are people, patients of mine that suffer just severely. They'll claim that they have a tooth, and they're like, this tooth is just so, it's hurting me so bad, and there's nothing that, there's no reason that tooth should be hurting them. And we'll even go as far as, after months of begging and pleading, remove a tooth sometimes, and have patients sign consents, and they come back and like, the pain is still here. And
so it's a referred pain from their TMJ.
Exactly, and so there can be all these.
When my TMJ hurts, which is rare, hurts in the ear. Is that common?
Yeah, it's a temporal auricular nerve that innervates the TMJ, so you can get the referred pain in the ear, and that's absolutely.
The same guy asked, hard or soft splint recommended?
We recommend a 3 millimeter thick hard splint with 1 millimeter of soft inside. So that's why it's going to a good dentist that's the current treatment recommendation. But it also varies by your situation and what we're trying to what's being treated. Again, it's your situation may vary.
So we'll put up your numbers, but just how do people find you? Do you have a website?
Well, RedmondDental.net is my website. Okay. My number's real easy. It's 205 Dentist.
Okay,
and I'm a very conservative dentist. We don't. I'm not a cosmetic dentist. I like to help people find solutions to their oral health problems. And I take a broad view. I take a controlled approach to where your problem is the center of my attention.